Good afternoon, everybody. It is a pleasure to be here on behalf of the Department of Gastroenterology at Jehangir Hospital, Pune. Jehangir Hospital is amongst the oldest hospitals in Pune, continuously serving patients for more than 50 or 60 years. We have today this discussion on occasion of Constipation Awareness Week. So this week is there every year, and the main aim is to improve awareness about constipation amongst patients, give them right guidelines, and also improve the awareness of constipation amongst primary care physicians. I have with me today a very eminent group of doctors who have been practicing in Jehangir Hospital for many years and seeing patients with constipation regularly on day-to-day basis. So on my left is Dr. Lalit Shimpi, who is a senior gastroenterologist, now practicing for almost 25-30 years. I have Dr. Sunil Pawar with me, who is also a consulting gastroenterologist at our department, Dr. Nachiket Dubale, and our youngest family member, you can say, is Dr. Pratik Sethiya. So today what we will be doing is we will discuss about constipation and a little about gut health. So constipation, as all of us know, is a very common problem. There is hardly any person who has not experienced constipation in his or her life. So what we will try and do today is try and address some basic questions which come to the mind of not only patients but also primary care doctors, and try and see how best we can approach with answers from all our experts along with me. So I think we'll start with Lalit. You are the next senior most. So you have been practicing gastroenterology for so many decades. And two questions I have for you. The first is, what are the types of patients you see in clinical practice? What are their complaints? Today we are not going to discuss about liver, pancreas and other aspects. So what are the complaints which patients come to you very frequently? And amongst these complaints, how many have constipation? So is it a major part of your practice? What do you feel about it?
So thank you. If we consider our OPD practice or what we practice in our clinics as outpatients, I would say the most common diseases or disorders or symptoms that we come across many times are functional bowel diseases, where patients come to us with various chronic symptoms which are bothersome to them, and they may be in the form of some upper gastrointestinal symptoms like reflux disease or heartburn or dyspepsia, indigestion. But we do have a significant number of people who come to us with lower gastrointestinal symptoms, and these may include patients with constipation or chronic diarrhea or irritable bowel syndrome, abdominal pain, recurrent bloating, gases. So these are the common things that we see in our practice. I would say about a significant number of patients, 15 to 20%, I would say, come to us with these kind of lower GI symptoms, and constipation is bothersome to a lot of these patients.
So many times when patients come and tell us that they are constipated, you have to sometimes dig out a history. So generally what is meant by constipation is that the patient is not passing stools, or maybe infrequent frequency of evacuation or incomplete evacuation. But there are so many other complaints like patients come with. So they call it as indigestion, they call it as bloating. Some of them even say it is acidity, and when you ask them, they say it is. So Dr. Sunil, can you tell as to which patient should we actually label as having constipation?
Thank you, sir. So constipation commonly is defined in various terms. So less than 3 times passing stool in a week is labeled as constipation. Apart from this, if there is an incomplete evacuation of bowel, that is also labeled as constipation. If patient is having difficulty in passing stool, it has to put lot of pressure, or if patient has to sit for a prolonged time on potty seat, so that is also a constipation. If patient is feeling blocked like thing while passing stools, that is also a constipation thing.
So are there any symptoms like which you would like to add to this, Nachiket?
The difference from the definition and what we see is a very common symptom is, as he said, is incomplete evacuation. So the commonest thing what a patient perceive as constipation is he's not able to completely evacuate his bowel, and he always feels that he has the urge to go, and that is the commonest symptom what we get, and patient come to us with this symptom, more of this.
And I think we also have patients who feel it very embarrassing to tell us that they need to put their finger inside the anus to bring out the stool. Would you agree with me?
Yes, I think this is one of the major problems or symptoms that some of a very particular group would have because they find it so difficult to pass motions. I think we need to, as clinicians, a lot of times make a distinction between people who don't get the urge to pass motions at all. So they don't get an urge for 2 days, 3 days, and then they consider. Or the other issue is they have the urge and they go and pass motions but find it difficult, in which cases they might need to strain at stools or sit for a long time, use digital evacuation maneuvers or instill water inside the rectum and try to get it out. So that is, I think these two major things are what are bothersome to most patients.
So I think this is very important. So when patients come to us with constipation, what we do as doctors is we first try and see what the patient means by constipation. The second thing is we try and see what type of complaint he is having. But very often, a lot of patients, they come to us saying, "Mujhe piles hai, I have piles." So if you look at it from our angle, we call the patient as having piles if there is rectal bleeding. But many times it is a term which is used very generally, and patients say, "I have piles and that is why I am constipated," or "I am constipated and I have piles." So can you elaborate on what actually patient is very often termed as piles by patients? So what should the correct terminology be? And
So as you rightly pointed out, there a lot of times there is a synonymous description, that is constipation is equal to piles. So many patients say I have piles, that's why I have constipated, and there is something coming out of the anus during defecation, they attribute to piles. All the bleeding is attributed to piles, where it is the other reasons also we should know. So very commonly, I have piles means I am constipated. So what I want to clarify here is piles is the result of constipation. Everybody has these vessels in the anal canal and lower rectum, and when they get enlarged and they cause bleeding, this is called piles. So always suggest to get an expert, get yourself checked, get examined, and then you can conclude whether you have piles or not. Piles is a result of constipation, not the cause of constipation. And not all bleeds are pile-related bleeds. And if there is a bleeding during defecation, there is an alarm symptom and you should get investigated as early as possible.
so Lalit, there are many patients, we have of course nothing against alternative medicine, but there are a lot of patients who say that they have piles, they go to an alternative medicine specialist, and on the basis of symptoms they get treated for piles. So is this the correct approach, or do you need to properly document piles by doing some correct examination?
Now, in our practice, many times we see that patients have assumed that they have piles and constipation and bleeding and pain, and then they go to these either alternative therapies or get treated just on an empirical basis, considering that this could be the cause, which is a wrong approach actually. So if you have this history of PR bleeding or bleeding per rectum, it is actually one of the alarm symptoms that we consider, in which cases we should definitely evaluate these patients and really find out what is wrong, because it is not a good practice to assume and treat. Rather than that, we should actually have a look and start treating patients.
So we should have the patient examined with a rectal examination.
Yes.
And check for piles.
Right. So at least in the clinics, when we do an initial evaluation, if we have a suspicion of like this, you don't need any very complicated or major procedures. Just a rectal examination or a local examination by your doctor should give them a certain idea. What it does is basically diagnoses what the problem is, and in case the rectal examination or a digital examination in which the doctor will examine locally or put in a finger and try to evaluate what it is. It's a basic test which may also rule out any anal problems and may give an idea to the doctor that actually the bleeding is coming from inside somewhere.
So I think your answer is a very important take home for patients, that they should not just attribute their symptoms to piles, They should have it properly examined by a proper specialist and then make a diagnosis of confirmed hemorrhoids piles. Now we see that constipation is very common in the general population. Almost 10 to 15% patients may be constipated, and as the age goes higher you find almost 30-50% patients being constipated. So obviously if 30-50% of the whole of Indian population which is older starts going to doctors, we will have no job other than seeing people with constipation. So when do you feel patients should go to a doctor with when they have this history of constipation?
Actually, most important answer to this question basically lies in what is the onset of your constipation? Since how many months or years you have constipation? And are there any alarming signs to your constipation? Like patients who usually have change in caliber of stools. Like initially the stools were very soft and very hard. Now there is suddenly narrowing of the stools, or sometimes patients say that the caliber of the stools is large. Sometimes it's blood mixed. So it's very important for us to identify these symptoms because these usually point out towards malignancy in elderly age group. So my message is all patients who are usually elderly with anemia, having been commonly evaluated, having the stool occult been positive with symptoms of constipation, should ideally undergo certain blood tests and a colonoscopy as a screening tool of measurement for colonic cancer screening. In various countries, in maybe US or maybe sometimes when UK task force, they have certain guidelines above 65 years of age, or those patients who have got a family history of colonic cancer should start screening program for a colonoscopy. And also some medical disorders, patients might having hypothyroid, those who are having diabetics, those who are having uncontrolled sugar, those who are associated taking some painkillers or NSAIDs, they should be thoroughly evaluated and they should be treated as soon as possible, because treating is very, I can tell you treating is simpler, but diagnosing the constipation is a little difficult because sometimes it might be different types of constipation. It can be slow transit constipation, it can be dysenergic constipation, it can be a normal transit constipation. So initially we should evaluate a person who is a young constipated, who is a middle-aged constipated, or who is an elderly constipated. Young patients usually have different symptoms and different disorders to have with. Elderlies usually have some different disorders to have with. There might be acute stress, there might be a lot of stress, along with patient might have constipation. So these things needs to be kept in mind when we actually evaluate constipation.
So I think if a patient has been having recent onset constipation, time to see a doctor. If the patient has been having long-standing constipation and there is a recent change in the type of stool or the change in his pattern of constipation, they should see a doctor. And of course, needless to say that if a patient has been having constipation and there's some other new symptom like rectal bleeding, weight loss, severe abdominal pain, then they should definitely see a doctor. And when the patient goes to a doctor, generally I think a lot of patients today, if you look at people who are above 50-55 years, they will be on so many medications for cardiac reasons, for hypertension, for diabetes. So how frequently, Lalit, do you find people who have constipation not because of any disease, but because of the various drugs which they have been on?
I think this is so that is a very important point that you have pointed out. Is many of these patients, especially those who are elderly and with multiple associated disease, someone has diabetes and even patients who are on cholesterol medicines or patients who are on antihypertensives, many of these medications themselves may cause constipation. So one useful thing to ask our patients is whether the onset of constipation has coincided with starting some new therapy, or whether their primary doctors have changed some treatment and then patients have started developing constipation. So this drug history is sometimes missed out even by the treating physicians or us, and we need to really go into detail of what the patient has been taking, because some of these medicines can definitely be a cause for constipation. And then if you are evaluating these patients in detail, it's really may not be a necessary step because your reason is already there in the medications.
So rightly so, I think many times when a patient comes to us with constipation, especially those who come to us with relatively recent constipation, we always ask the patient as to what do you feel started off your constipation. And in fact, many times the patient will give us an answer that, yes, this drug was started, or I did something, whatever, and then the constipated patient started. Now, Pratik just described us about which patients should see us. And if you can, one of the common tests which is done for this is a colonoscopy. So if you can briefly tell how simple is it, because many people when you say that you have to have a colonoscopy, they say that no, I don't want it. Then it is very difficult, it is very painful. So I think if you can allay all these myths, then patients may become more forthcoming for having a colonoscopy when it is required.
Right. I think in the evaluation of constipation, colonoscopy is a very important test, and there are various apprehensions and myths about getting a colonoscopy done. A colonoscopy is essentially a test in which the doctor will pass a flexible tube with a camera at the end, and this is passed per rectally, and then we evaluate the whole of the large intestine. On an average, I mean, people have concerns because of two things. Is one, because of hearsay, they've heard that no, this is a very painful test, we don't want it, and we don't want to get that kind of. And the other thing is an associated embarrassment that is there with getting such a test done. But I think it's important to know that one is that it is a procedure which can be done on an OPD basis. You don't need admission for that. Generally, some preparation is required, or a laxative solution is given to the patient so that the bowels are clear, so that the doctor can go inside and see properly and visualize the entire colon in detail. And this test generally would take, say, around, on an average, say about 15 to 20 minutes for average colonoscopy to see the entire colon. Generally, we try to make the patient a little relaxed by giving a mild sedative. Someone who is very apprehensive or anxious, we can always do a colonoscopy under a very short IV anesthesia. But both of these groups of patients can be in the hospital maybe for a couple of hours after the procedure, just for observation, and then they can go home. We would of course ask them, because some sedation has been used, we tell them not to drive back on their own, and they should be accompanied by someone when they come for a colonoscopy. But per se, if it is done properly and by expert hands, it is not a very painful test. There is some discomfort because some gas is inserted inside the colon to visualize the colon properly. But otherwise, it's not a very painful test as it is perceived to be.
So I think you have allayed most of the fears, and somebody who has it at the back of his or her mind that they should have a colonoscopy may probably be more forthcoming to have it done. And then of course the doctor will decide whether it's required or not. In fact, interestingly, we have so many of our patients with colonoscopy. They have taken the preparation in the morning and they have cleared their bowel like never before in their life. And they ask us whether they should take this preparation once a week or twice a week. So what is your take on it?
So, what we give for colonoscopy is just to see the bowel from inside. That's a requirement for it. So, usually the laxative and the preparation we give, that's polyethylene glycol, that also comes as a laxative. So this can be given, but not in the quantity for which is required for colonoscopy. So regular bowel movements, by giving this laxative, is justified. Polyethylene glycol becomes a part of our medical armamentarium, but not at the quantity which colonoscopy. Otherwise, the patient will get dehydrated and will have a lot of diarrhea. So we don't want patient to have a diarrhea every day. We want just a bowel movement for the patient to get relief of his constipation.
I think this is very important because I have had some patients who automatically on themselves started taking this preparation twice a week, and patients have to be cautioned that it is not advisable. It does have side effects, and regular laxatives, like Dr. Nachiket said, in smaller effective doses for that individual patient is what we should use. Now, when you speak about constipation, there are both groups of patients. There are some who may feel it is normal for them, there is no need to see a doctor. But we discussed as to who should be seeing a doctor. Then there are patients who may not really have anything very important, but it is fixed in their mind that they have a colonic cancer or tumor which is causing the constipation. So you have been doing colonoscopies for so many years for people with constipation. So do you really find colonic cancer so commonly in people who have constipation, or is it a kind of body tendency or poor fiber intake and very less patients who finally turn out to have?
Patients have this fear of colon cancer when they get constipation. So, but constipation in colon cancer is quite rare. So, whenever we find a patients, many patients of constipation, the etiology is majority of dietary and lifestyle. It is less fiber intake, less exercise, less fluid intake, or some functional component like irritable bowel syndrome with constipation variety. So, in majority of patients of constipation, when we evaluate, colon cancer is very rare. It is only common only if patient is very old age and new onset constipation. If those subset of patient, if we consider, then probably few more percentage of colon cancer.
Any different views on this?
As rightly pointed by Dr. Sunil sir, but I feel colonic cancer is a dietary. I mean, majority of the people who consume a lot of beef, initially it was linked to have CA rectum in the middle-aged group. But I feel colonic cancer should be screened initially with a stool local blood, a few blood tests, and then if they are positive, then you might go for a colonoscopy. Like recently, I had a 48-year-old female just complaining of constipation with incomplete bowel movements, making bowels every alternate days for the past 6 months. But that doesn't mean that she was not having colonic cancer until I did a rectal examination and I find a growth below. So it's very important to screen, as Sunil also pointed out, to doing a rectal examination also. So constipation in middle-aged group can also present as colonic cancer.
So, like we just discussed, many times we do colonoscopies on so many people who have constipation, and we find it is normal. So, other than any growth or some mechanical obstruction in the large intestine, there must be some factors in the lifestyle or diet which contribute to constipation. So, which are these factors?
So I think what dietary evolution we had in the recent times have risen the patient population of constipation. I mean by dietary evolution is more refined we become, the more problems we get. So less of fiber, less of fluid intake, lot of cola, lot of fast food, what we want to consume, and it is quite tempting to have it often. And I find that younger population with a lot of food fats, like people having a lot of protein powder, bodybuilders, you consume a lot of protein, less of fiber. So diet which consumes less of fiber, less of fluid, more of refined things is the main dietary intervention in these set of patients. So I recommend that when a patient comes to me, I always ask him or the accompanying person how many fruits he has. So they say occasionally we have fruits. So I advise them to have a daily 2 fruits a day, 3 to 3.5 liters of water, not fluid, but water per se. So this remains the basis of diet, and a good, of course, regular exercising to have your abdominal muscle tone to give you a good relief. So this is the basic thing. Any kind of fiber, either soluble, non-soluble fiber, less of refined food, and good exercise is the advice. To start before giving them medication is the thing I usually tell them.
So I think very important point which you brought out is about constipation, which we find in very young people who look very fit. And like you rightly said, the whole focus from their trainers or their advisors is on protein and muscle building, and the fiber part is overlooked. So I think this is very important that people who are into this type of gymming and bodybuilding, and if they feel that they are constipated, they should make sure that they are taking a balanced diet in addition to the protein supplements. So now we saw that a colonoscopy may be normal in a lot of patients, and structurally there is no obstruction. But sometimes these patients may have a slow colonic movement, so the colon may not really push the stool from the right side to the left side, and then it may not come out. So in just a couple of minutes, Pratik, if you can tell us, are there any tests to tell us whether the colon is functioning properly or not?
So we have few tests which actually can tell us. First one is to decide whether the transit is slow, normal, or maybe rapid. So maybe slow transit constipation we can do by a colonic transit studies, in which we ask the patients to have a proper protocol, have some radionuclide capsules being swallowed, and then after 24 hours, 48 hours, and at 60 hours, we do X-rays. And after looking at the X-rays, the pills which are actually there in the colon, then we identify whether the patient has actually evacuated those pills completely. So that's one way of assessing transit. Second way of assessing motility is basically by a manometry. Manometry is a tool which basically assesses the dysynergic defecation, whether the abdominal or the abdominoperineal muscles are being coordinating properly or not. They again are divided into 3 or 4 types, which I think is a part of this discussion. But definitely abdominopelvic coordination of muscles and evacuation is very, very important. There is an evacuation protocol. We sometimes, as discussed, do colonoscopy, some blood test, colonic interventions, normal studies, like there may be colonic wireless capsule studies to identify the transit time again. So these are basically very done to evaluate the motility of the colon. These are functional studies. The structure studies is definitely by a colonoscope, and associated medical conditions like diabetes, thyroid, some lead poisoning, many of the Ayurvedic preparations have got lead, so that needs to be evaluated on forefront.
So far we spoke so much about when should a patient really consider himself or herself as being constipated. Then we discussed as to there are so many people with constipation, but who should come to a doctor. And very important thing we told is that people should not call piles, I have piles, and then get misled. So they have to have a proper examination for this. And what are the tests which we do in select patients for constipation, especially a colonoscopy. We look at drugs, we look at other medical conditions like thyroid disorders and any other alternative medicines if they are taking. Then other very important point was that every patient with constipation need not have a fear of colonic cancer. And like Dr. Sunil alluded to, we don't very commonly find colonic cancer in people who are constipated. And many times the colon is normal. And in such patients today you have means to assess whether the colonic function is proper or not. Now with this background coming to treatment, which we are not going to talk about individual drugs and how you should use them. But a lot of people tell me, or I'm sure to all of us, that yesterday I went to the chemist and I said I have 15 days constipation and he's given me this and I am taking it and I am better. So there are a lot of these over-the-counter medications which people take. And there are two things which happen. One is the chemist may, it's okay, I mean, for a first line 1 or 2 days taking something, but he may not really know what the patient has. And in fact, if you look at older patients, we have so many patients who go to the chemist, they take a laxative, then they get loose motions. Then they again go to a chemist, then they feel they are loose motions, so he gives an antidiarrheal, they get constipated and the cycle goes on. So tell us something about over-the-counter medicines, and till what, you can't say that nobody should ever take over-the-counter medicines. They would be taking. So at what's the point when they should stop it? Is 1 day, 2 days, 5 days, 10 days or 1 month?
If constipation is for a short duration, like especially people are, when they travel, there is a change in dietary habits, so we expect constipation for 2-3 days, or in function times, or in some illnesses. So short duration constipation, for them, if they take over-the-counter laxative, that is okay. But if their need of laxative is more than few days, maybe it is not an exactly 5 days or 7 days, but maybe 7-8 days, if even after that their need of laxative is not going away, then they should definitely consult a doctor whether why this constipation is not going away.
So when they come to us for treatment, other than lifestyle modifications, increasing the fiber in the diet, proper exercise, very important today is the circadian rhythm, because there are a lot of people, especially in the information technology field, who have completely reversed their circadian rhythms or their sleep cycles because they are servicing people who are in some other time zone like US or UK or wherever, and then their working day starts at 5 p.m. and ends somewhere at 2 a.m. and that I think also is a very important contributor to constipation and so many gut disorders. So if a patient comes to you with constipation, just for the understanding of patients, when we say that we are giving a laxative is something which will ease the process of passing stool. So how do they really act in very simple terms, like do they increase the colon movement or what do they do?
So what we do usually is type the constipation, what type of constipation the patient has, depending on his getting a history of his symptoms. So laxatives we can divide into stool softeners, stool bulkers, that we can form the bulk of the stool, or which can stimulate your gut. If you have a constipation, which patient do not get a sensation every day in the morning, they usually have a very slow transit. They get sensation in once in 2 or 3 days. So depending on the type of constipation, either they give them stool soft. Some people say that I have constipation because I have hard stools, so they do well with stool softeners. Patient who have no sensation, they usually do well with stimulant laxative. You can stimulate the colon, which can propel the stool further. Some people have, as Pratik said, they have obstructed feeding. They try to pressurize themselves, do a lot of straining, but they can't get the stool out. So their laxatives may or may not work. They may have to undergo some tests like anorectal manometry, etc. But laxatives is softener, bulk forming, and stimulant. Some recent ones can also secrete some fluid in the intestine and increase the fluidity of the stool. So these are the commonly available laxatives, and we prescribe them according to the type of constipation. So no one type of laxative fits all the patients.
So very nicely described. So there are laxatives which improve the movement of the colon, which draw in water in the large intestine, which increase the bulk in the large intestine, and which cause some irritation, and then they stimulate the colon. And then you have some what are called as lubricants. So way back about 40-50 years back, a lot of our grandmothers used to say you take castor oil once a week, and it was one of the most difficult thing to take, but we had to swallow it on the advice of our grandparents. So you have so many types of laxatives, and I think it is, like you rightly said, very important to say what type of constipation it is, and then tailor the laxative as per the patient's findings and response. There are some patients who may respond very rapidly to a laxative, some require a combination, some require increasing dosages. We have been using laxatives for so many decades, and like we discussed, a lot of patients, laxatives are very commonly used and for a very long term. So are there any side effects particularly, or by and large are they safe? I think if they are taken by the advice of a doctor and the patient is probably properly educated about taking them, I don't think there would be too many side effects.
No, the only issue sometimes comes, especially when patients are self-medicating. A lot of times they take more of stimulant laxatives because it gives them a better form motions and they go more regularly. There is, of course, there are effects of these stimulant laxatives on the colon, on the structural issue. So you do see structural changes like melanosis or things that we see on a colonoscopy, which will tell us that it is a problem. More than the side effects, because many of them are effective for many patients, but more than the side effects is the dependence part, and that is something which can be problematic, because once you are starting yourself on stimulant laxatives, so it's important that you see a doctor and the doctor prescribes what you actually require. So osmotic laxatives are those which draw water inside the colon, and they will cause a smoother motion, or as Dr. Nachiket said, stool softeners also may work. So you may be doing an overkill by taking stimulant laxatives when you actually don't need them. And the problem with that comes is that dependence starts at some point or the other if you're taking it for years. And then it's very difficult for either you or your doctor to get you off those medications. So I think that is one concern that is there, which should be looked into by your treating doctor when they're treating you for constipation.
So would we be correct if we say that by and large they are safe, but you should avoid getting dependent on them, and whenever the effect is perceived and it remains stable, you should try and taper them off to a basic minimum dose?
Yes, I think so. That is a good way to go about it.
Now, last question about constipation. So this session actually, like I said in the beginning, had two parts. One was constipation, and second we were supposed to discuss a little about gut health. Now the session is supposed to be about 40-45 minutes, and I think we are halfway through. So we will ask one last question to Pratik about something which is very commonly done in constipation and which is called as colonic hydrotherapy. So there are scores and scores of patients who are constipated who have been also taking colonic hydrotherapy, and they ask us whether they should take colonic hydrotherapy. So in very brief, whether it's a myth or a reality.
So colonic hydrotherapy basically is cleansing or putting a lot of fluid inside the bowel through a machine, and it cleanses your bowel. That's what everyone who has got a hydrotherapy machine claims about. Basically, it flushes out your bowel. That's what they say. But basically, if you have a proper diet, you're properly taking adequate fluids, and you're not constipated, there is no need of doing hydrotherapy. Firstly. Secondly, those who are constipated, it's going to be a temporary relief for them, maybe about a week or two, and he might feel all right for about a couple of weeks, and maybe then he'll feel, though I'm at the same point again where I was. So I guess we should not forget the etiology and the basics of constipation, what they are, what is causing constipation, why you are constipated. Colonic hydrotherapy will temporarily relieve you for some time, but for a long-term relief and for treating you from a proper perspective and etiology wise, I think colonic hydrotherapy is not an answer. The answer to the question is identifying the problem and treating meticulously and accurately. You should know your constipation, that is most important, and the patient should know his constipation, why is he constipated. That's more important nowadays.
So I think we've had a very wonderful discussion on constipation with all my eminent colleagues and who have been into practice for so many years. A lot of it is actually because it is for people who have this problem. A lot of it is wisdom talk more than very scientific papers and mechanisms of actions which we would discuss in scientific meetings. And I'm sure that a lot of myths and misconceptions about constipation we would have allayed in people who are listening to this discussion. The second part, like I said, is going to be a very short one, and it is basically directed at gut health. So if you have a patient who wants to know that he or she has diabetes, he can check his blood sugar. If it is high, we can tell, yes, you have diabetes. If there's a patient who wants to know he has hypertension, he can check his BP and then we can say, yes, you have. So by and large, there is no great definition of gut health. But by and large, I think we should assume that a person who has no GI symptoms, he is maintaining his weight, he should be considered as having good gut health. Now, if you look at gastrointestinal complaints, I like to divide them into A, B, C, D. So A is abdominal pain and acidity, B is bloating, C is constipation, and D is diarrhea. So most of our patients, if you agree, will fall into this. So just as you have preventive cardiology, where you control the BP, you give statins and so many drugs, what is a general overview of diet which you will advise for people? So when you say diet, I think three things come to mind. The first is timing, the second is content, and the third is variation. So variation is because you may be a person who is traveling, and those who are traveling within India from north to south, those who are globetrotters from one end of the globe to the other, and the food pattern changes. So a very brief take on this timing, content, and variation.
I think lot of our gastrointestinal diseases or functional problems that we see are actually lifestyle and diet related. So they may start with the wrong diet or they may start with the wrong lifestyle. And that is something that we need to take care to prevent the problems from happening rather than trying to treat them when they actually come. So if you see the upper GI symptoms that we normally have, most people would have some degree of reflux or acidity or heartburn, which they get frequently, or they may be dyspeptic and they may have this loud burpings and gases and having upper abdominal discomfort. So most of the times it is because of two things, as you mentioned very rightly. The timing of meals is very important because with the fast growing world and traveling becoming so frequent, stress being so important, as you said, many people work in shifts and that really changes their dietary patterns. So I think maintaining that timing is very important. One fad that has come now, and it has a scientific basis, of course, for weight loss is intermittent fasting and not having anything for 12 hours and 14 hours. And I think it may work towards your weight loss, but it does have its problems as far as GIT is concerned. Now you have someone who is eating at 8 o'clock in the morning and then directly at 8 o'clock in the evening. It has a problem because through the whole day your stomach is secreting acid, but there is no food to really neutralize it, and that is why these acid peptic disorders increase. So as far as maintaining a gut health and timing is concerned, I think avoiding overeating, because many times with this intermittent fasting you tend to overeat because you are so hungry at the end of it. So I think avoiding overeating and having more frequent and smaller meals is what is something advocated as far as your upper GI symptoms are concerned. But definitely you can try to avoid food stuffs which are street foods, for example. You go and there is a tail of vada pav, you are hungry and you have that, and then you start having reflux problems. So I think if you can avoid these, for reflux, one would say that if you are taking an excess amount of spicy diet or high fat foods, processed foods, an extra or too much of caffeine or coffee through the day, some citrus fruits can cause reflux. Fatty foods can also cause you to have a lot of dyspepsia or indigestion, kind of bloating kind of symptoms. Then there are some foodstuffs which we call as high FODMAP, which stands for fructooligosaccharides and diacylcyl. So these are foods which may increase gas production in your body. So these are certain foods that you can tend to have more and they cause problems. But ultimately, I think everyone should figure out what foodstuffs give them the symptoms and try to avoid them. That's a very simple solution as to how you can really avoid getting problems as far as GI is concerned. For the lower tract, as we have been discussing over the last half an hour or so, a diet which is good in fiber, which is less in refined carbohydrates, and a good amount of fiber, fruits, green vegetables. I think we in India are very lucky in that there is such a variation of food which is available for us. And our traditional Indian meals have a good amount of everything in them, including fiber, including lentils. So the nutrition part, the fiber part, all of it is taken care of very well in our homegrown food. So I think that is something that you should stick to. The younger generation also probably needs to learn that this is the kind of diet which will keep you away from most GI diseases.
So nowadays there is so much information available on the net, and probiotics, microbiome, and these are buzzwords, and everybody feels that it is all in your gut and your bacteria inside. And so many people of various origins, they take Yakult or something like that every day. So these are basically probiotics. So when we mean probiotics, it means that these are actually bacteria which, when given to the person, they are beneficial to the person who takes them. Who should be taking? Are there specific indications, or you feel everybody should just take a probiotic?
As you rightly said, it's more of kind of fad to have a probiotic universally. Scientific evidence tells us that the probiotic work best in patients who have recent episode of diarrhea, where the bacteria get disturbed and they take 4 to 6 weeks of probiotic, they come to normalcy, the diarrhea gets controlled. Another important disease-related indication is the inflammatory bowel disease, where patients will benefit initially with having a good homeostasis of bacteria, host and bacteria, where probiotics do help in initial days. Yakult and other products will have probiotic and their temporary good effect patient may feel, but their quantity of so we can't prescribe Yakult for a disease patient like infectious diarrhea. You can't. We don't usually prescribe Yakult because the amount of probiotic which is required is not defined in these commercially available products. So diarrhea, inflammatory bowel disease, sometimes liver disease, the probiotics do have beneficial effects, and this has been scientifically proved. These are, I think, indications.
So not an anti-Yakult talk, obviously, but when people are taking it, they should be aware that it is not a very scientifically proven formula. They can take it for a certain period, but there is not much point in keeping on taking for years on end, hoping that the aging may stop or the gut may remain healthy. Now, I think the last part, what we'll do is we'll do a little differently. So we'll have some quick takes on certain topics. So I'll ask each one of you, and you give what is your quick take on that question. So first thing is, when we were doing MD medicine, MBBS, when somebody came with these type of complaints, we said it is all in your mind, and we gave antipsychotics and hoped that the patient would get better. But now it is realized that it is not exactly only mind affecting the gut. So mind and gut, one way or two way?
I think it is a two-way thing. What we have is a brain-gut axis, what we call, and many of the hormones from the brain or the signals that come down to the bowel, they affect your bowel movements and your bowel function. And at the same time, whatever happens in the bowel definitely affects your mind. So it would be a good approach for every doctor to take this gut-brain axis as an important one and try to address both of these issues.
So Sunil, how does the mind affect the gut? One quick take this is.
See, as
commonly when we were children, if there was an exam coming up, we used to have this feeling of going to a washroom, and then it is a kind of mind affecting the gut.
when there is anxiety or stress hormones kicks in. Secondly, there is various nerves like they supply from brain to gut. So whenever there is anxiety, then you get an urge to pass stool, multiple stool. In anger, sometimes patients get pain or bloating sensation. In stress, there can be constipation also. So it is a hormonal plus neural connection with the mind and gut which affects this.
So for peptic ulcer, we used to say rightly, I think, hari, worry and curry.
Hari, worry and curry.
And
Yes.
now we can add pylori to it. H. pylori. So has the focus shifted in treatment from purely writing these mind medicines? So we have so many drugs which now can target the bacteria inside, the nerves which carry the sensation from the intestine to the brain. So do you see a shift in, or are we blessed that we are having more and more drugs to treat these patients, and do you feel that they really benefit these patients as against only the mind medicines which were written about, say, 15-20 years back?
So, as we come to know more and more about gut-brain axis, we know that same neurotransmitters and hormones act in both the systems. The GI tract is the largest nervous system, they say, in the body. It's bigger than the neurotransmitters, bigger than the brain also. So, as the science progresses, we have newer medicines. But I think which medicine for which patient depends on which is a patient with a lot of anxiety and some amount of GI symptoms who come to us, we focus on the mind and treat them for their anxiety first. For patients who have primarily disease of the brain, disease of the gut, and which affects his brain, we target them for treating their gut disease first, which can solve their anxiety issues. So depend on the individualized patient who has more symptoms pertaining to which system, and then we treat it.
So quick take is for Pratik because he is the earliest here. So it is generally said that an older physician, maybe I am there, treats many disorders with one drug, and a younger physician takes many drugs to treat one disease. So you have a big armamentarium of drugs which is now available. So a little about newer medicines which he spoke about. We don't want the details of how they act, but which are the areas where things have really changed, like peptic ulcer, H. pylori, or
Most importantly, the management is a very tailor-made approach. Every patient is different. Every patient will require a different therapy based on that. Initially, for peptic ulcers, we used to our forefathers and even start from ranitidine or maybe cimetidine. Then it focused down to ranitidine, and now we are the latest in having a potassium combined antagonist blocker, PCABs. So the journey from H2 blockers to PCABs is a large one. Firstly, the journey from treating anxiety from a typical antipsychotics to an atypical antipsychotics, and to maybe a SSRI or maybe a selective serotonin reuptake inhibitors, or maybe a tricyclic antidepressant, which actually have effect on gut and it decreases the anxiety also. Sometimes these drugs have dual benefit. They are classified as anti-anxiety medicine, but they actually work on gut. So many people actually say that, so why have you prescribed me an anti-anxiety medicine, or why have you prescribed me this medicine, which is not I'm not a stressful person, I'm not a person who is a psychotic patient. So these drugs actually are required to soothe down your bowel. Sometimes they might have some sedative effect, they might have sometimes a little bit of bowel cramps, but definitely I would like everyone to tell these medicines are sometimes required for short term to decrease anxiety, to regularize the bowel motion. Initially, as Sir pointed out, a one drug and multiple effects. Nowadays, I would rather tell one or two drugs with a tailor-made approach to the patient. If the patient is having both upper and lower GI complaints, you should be treated accordingly, and he should be treated with minimum of the medicines. 3-4 or maximum 3-4 minutes, because the person who is coming to us is always going to have some of the other problems. He might be diabetic, he might be hypertensive, and with you making a list of 5 to 6 medicines is going to add to a pill burden. So accurately diagnosing when treating him is very important. Treating rightly is very important. Treating neuromodulation drugs is also very important and equally important. So we need to approach them. Those who are diabetics might have a little bit of pain. Sometimes you might give a little bit of nerve soothing effects. Sometimes you might give a nerve sedative so that the pain in the abdomen goes away. Sometimes the neuralgic pain is in the anterior abdominal wall. You might need to give them. So basically, giving abdominal medicine as well as sometimes neuralgic medicine is equally important in our GI practice.
So there is one question about gallstones, whether they are related to constipation. So there is no real direct connection. And to make the end a little interesting, we'll have a rapid fire. So it is true or false or myth and reality. So there are 2 questions each, and you can just answer in one-liners. So constipation is very common. True. So colon cancer is a common cause for constipation. Is it true or false?
False.
Yeah, so colon cancer not very common. We discussed this, and constipation is readily managed by over-the-counter laxatives, and there is really no need to see a doctor.
False.
Then one for you is once a month castor oil or hydrotherapy or the colonoscopy preparation, it keeps the gut healthy.
False.
Probiotics for all.
False.
So select your patients, and patients beyond the limit should not keep on
Continue.
self-medicating. Leaky gut, gluten, candida, these are things which lot of our educated very net savvy patients ask us. So, true or false or may be correct, but without scientific basis.
May be correct, and the science is still evolving to comment.
So, candida in the gut is myth or reality?
It's a common sign in our gut too.
It is a common misconception, but there is no way to prove it, and so it should be called as false. And last is mind and lifestyle are important contributors to most of the problems which we discussed today. True or false?
Absolutely true. And I think this is the crux of it.
So I think we had a fairly good discussion on two aspects. One was constipation, and second was a little touch on gut health and how one can. So if you look at a lot of these problems, we find that these are disorders rather than diseases. It may bother the patient quite a lot, affect the quality of life, but we need to have caring doctors. So it is not only writing medications, but giving adequate time to the patients, talking to them, trying to find out what caused. And if you, in very simplistic terms, put 3 bars like this, one is for the lifestyle, second is for the mind, and third is for any disease. For these type of complaints, I think the disease bar will be the smallest, and mind and lifestyle bars will be the biggest. So I'm sure this discussion was fruitful to the audience who attended it, and we have tried to allay a lot of misconceptions, myths, and it should help in properly taking care of yourself, going to a doctor when it is really required, and avoiding wrong concepts in your mind like piles, constipation. And you have proper definitions now which we discussed, and I'm sure it is worth the time spent by people who attended this program. So on behalf of Jehangir Hospital, the Department of Jehangir Hospital Gastroenterology, and all my colleagues Lalit, Sunil, Nachiket and Pratik, my sincere thanks for everybody who attended this program. Thank you very much.